My name is Andrea Wagner, and I am the team lead for RPIW number 2, Saskatchewan Cancer Agency, Regina Capel Palliative Care, Pain and Symptom Management. Welcome to our RPIW report out. I'm very pleased to introduce I'm very pleased to introduce this outstanding team who will introduce themselves as they come up to speak. Do we have the photo up? And now the project form. The purpose of this RPIW is to reduce time for the Allen Blair Cancer Agency patients to access pain and symptom management from Regina Capel Palliative Care outpatient clinic. The other purpose of the RPIW was to introduce the distress screening tool to the Allen Blair cancer patients' nursing assessment to be used with every patient, every time measures. So these were the kinds of measures that we were looking at through this process. So the number of urgent patients seen within 24 hours, the walking distance for the Regina Capel admin support as well as the physicians, the lead time for patients to access pain and symptom management, the number of complete referrals, and the number of complete nursing assessments, the capacity of the palliative care physicians, the number of forms used in the process, the setup time for the palliative care admin assistant, and the cycle time for patients.
Good afternoon. I'm James Haney. I'm the Provincial Leader for Quality, Safety and Risk for the Saskatchewan Cancer Agency. And I was the sub-team leader on this project. And I guess the best way to jump off here is to look at our value stream. Our value stream started from the moment the patient came into the cancer clinic to the point in time that they had a visit in the Regina Palliative Care outpatient clinic. Two key areas of this value stream that we identified were the nursing assessment of the patient and the handoff between the cancer agency and the RQHR. For our process, the TAC time was 4 minutes and 4.6 minutes.
Good afternoon. My name is Tim Dieters. I'm from a quality improvement consultant with the Saskatchewan Cancer Agency. So the team identified several areas that they thought could require some improvement in this process and created some idea sheets. So the first one you see up there, the most significant area for improvement, was the problem created by having 2 separate electronic medical records for the cancer agency and one for the palliative care outpatient clinic. In the current process, patient information is stored in 2 separate locations and difficult to access for each organization's staff. This creates a lot of back and forth between both organizations and creates the waste of waiting, motion, defects inventory, and impacts patient safety. So the second form, another problem that was identified by the team was a problem with the referral process. So the urgency scale on the form was not well understood, and instructions and process times were not always followed. This creates the waste of defects, waiting, and could also impact patient safety. Finally, the last idea sheet. The team identified there is no standard approach to a nursing assessment. While patients' needs are largely met, there is no standard in place to guide the conversation with the patient regarding the symptoms they are experiencing, and this creates the waste of defects and can also impact patient safety.
Hi, I'm Joan Morris, and I'm the site manager of supportive care at the Allen Blair Cancer Centre. Patient distress has been recognized as the 6th vital sign in patient assessment. Prior to the RPIW, screening for distress was carried out using 2 nationally recognized tools. It was completed by new patients only prior to attending the clinic. Some patients did not receive it on time or forgot to bring it with them or did not understand how to complete it, resulting in errors in reporting. As a result of the RPIW, the standard work process involves reception staff handing out the distress screening tool to all new and review patients and requesting it be completed in the waiting room. All patients are also given an instruction sheet on how to complete the form. Completion of the assessment by the patient is now taking place just in time and is the most current self-assessment of the symptoms made by the patient, thus reducing the risk to patients and increasing patient satisfaction as the management of their symptoms is discussed, recorded, and referrals are made to other healthcare practitioners in a more appropriate and timely manner.
Good afternoon. I'm Donna Kennedy, one of the registered nurses in medical oncology at the Alan Blair Cancer Centre. Part of my role was to help develop one form for review and one form for new patients. Previous to creating one form, we used to have two forms, using a new patient form and patient review workshop. Now we have created a patient appointment sheet, just one form. To create this form, we combine the information from the new patient form and the review worksheet. We added a standard nursing assessment, a medication review, and updated the requested investigation area. By creating one standardized form, it will promote consistent nursing assessment for our patients, increase quality of the nursing assessments, create less inventory, and most important of all, patient safety.
My name's Pauline Fox. I'm one of the registered nurses at the Alan Blair Cancer Centre. Part of my role was to help develop a standard nursing assessment. The goal of standardizing the assessment process is to ensure consistency for every patient every time they visit the clinic. Nurses were observed during current practices, and a routine nurse-patient assessments were being done. We're taking an average of 8 minutes per patient per visit. After implementation of the new nursing form and the distress screening test for review and new patient visits, it was found that the average time of a nurse-patient assessment was not significantly different at 7 minutes and 45 seconds. Our plan is to implement these changes for every patient, every visit, starting next week.
Hi, my name is Terry Lynn Lowe's, and I am the admin assistant for the palliative care physicians. Before RPIW, the palliative care referral forms we received from the Alan Blair Cancer Centre were completed only about 40% of the time, meaning I spent 60% of my time searching for more information. During this week, the form was revised to make it more clearly defined.
Hello. I'm Dr. Muhammad Salim. I'm the site leader for medical oncology at ABCC and head of cancer services for RQHR. What we have done, we have classified patient referral into 3 main categories. Previously, there was only one. Into emergent, that needs to be seen within 24 hours, and physician-to-physician contact is necessary. Urgent within 1 week, non-urgent within 3 weeks. The benefits are patient get timely care as per their need, and the second, there is waste eliminated, which was going on in the current state, because clarifying what is the urgency of a specific referral.
Before RPIW, I did not have access to the cancer clinic's electronic medical records. Therefore, I had to contact the clinic to request patient notes. I would walk 24 feet to the fax machine to keep checking to see if the notes arrived. If they did not arrive prior to the patient's appointment, I would have to call health records to request the notes again, resulting in duplicates, resulting in waste. Only the last approved note would be faxed, so we would likely be missing valuable current patient information. During an outpatient appointment, the doctors often call me to retrieve MRIs, scans, or lab work. Therefore, I had to call health records, wait for health records to fax reports to me, then take the report from 4F to 3A, which is 220 steps, taking approximately 3 minutes. In the meantime, the patient and the doctor would be waiting. After RPIW, the doctors and I now have access to the clinic's EMR and PACS. Due to this, I will save 15 to 20 minutes per referral. Basing this on 300 referrals per year from the cancer clinic, I am saving 100 hours or 2.5 weeks per year. We now avoid duplicate notes, which eliminates waste. I can also estimate that time will be saved for some of the cancer clinic staff, as they are no longer doing these tasks for me. I now have access to patient info, such as next of kin and valuable instructions. For example, please call the daughter directly, as her father is hard of hearing or confused, etc. This will result in less no-shows or missed appointments. I will be able to view when patients have radiation, CT SIMs, or chemo, so I can schedule outpatients adjusting to their availability while on treatment. I consider this patient-centered, as it saves the patient unnecessary time, travel, and expense.
Hello, everyone. My name is Monica Beale. I'm a radiation oncologist and site leader of radiation oncology. I think you can appreciate how huge it was this week to get access to the EMR. The spaghetti diagram shows a lot of the travel that physicians had to do when they had to go from their offices on 4F down to 3A, and a lot of the inefficiencies for how they had to do their dictation. This is also really significant for our patients. When a patient comes to see any doctor, they assume that there is just one chart. Those of us who work in healthcare realize that there's multiple charts, and that can be a safety issue. If you can imagine some of our patients who've been on chemotherapies and radiation treatment for many years, they may not remember everything that's been done. They will just assume that the other doctors will know. So things can be missed. So we think that this has been a huge benefit for patients in terms of improving quality and safety. So we've been able to move heaven and earth, thank you, Kevin, to get EMR access for the palliative care team. They now are able to access the clinic chart from the palliative care unit. They're able to do the dictations right in the room. They're able to access the full patient chart, so they can look at all the historical notes, they can look at labs, they can look at imaging, and you can appreciate all of the rework that's saved based on what Terry Lynn has told us. We think that with this improved efficiency, it may allow an additional 1 to 2 patients to be seen each week by the palliative care physicians. So this is huge for our patients in terms of access. And there's reciprocal benefit for our staff as well, because not only will palliative care staff have real-time access to our charts, we'll have real-time access to their patient information. So this is just a really big home win for patient quality and safety.
Hello everyone, my name is Louise Frederick, and I've had the privilege of representing the Saskatchewan Cancer Agency Patient and Family Advisory Council on this initiative. And I need to tell you that I've witnessed an incredible depth of care and concern for patients' well-being, and also a process that highlighted the benefits of collaboration, communication, cooperation, the least of which is recognition and acceptance of the patient as a valued partner in the process. Also, the implementation of processes that can only improve the patient's awareness of where to turn to and for what as issues arise through their cancer journey. The process that I was involved with involved collecting documents, talking with stakeholders, and reviewing the documents and the resources currently available. The decreased awareness of resources on the part of the patients and the clinic nurses became evident, as was the need for the patients and nurses to have timely access to and consistency in information. We decided that the patient and family supportive resource sheet would bridge the patient's gap in information and should be given to all patients. A covering letter introducing the patient to this resource was developed, and both these items are now going to be given and included in the new package or new patient package. To meet the resource information needs of the clinic nurses, the document inventory of all resources list in the Patient and Family Resource Center will now be made available to all nurses. You need to know that this was, from a patient's perspective, was very empowering, this experience. I'm confident that patients are being listened to and can go away from this process assured of a commitment to people talking the talk and walking the walk. Thank you for allowing me the privilege of being involved. This is really a game changer for patients.
Hello again. One of the key documents that we used throughout the week was known as the newspaper. And of the many items, 45 I think at last count, there's only one item that remains that we'll be working on in the next 30 days, and that's ensuring that the new forms that were created are reviewed by the appropriate forms committees to ensure standardization on the chart.
That's great. And that is actually just one form that needs to be reviewed. So so the final results. The high level, so through this RPIW, the feet traveled by the palliative care physicians and admin support was reduced by 99%, or 139 kilometers a year. We reduced the number of forms in the process from 5 to 3 and reduced the setup time for one part of the process from 90 minutes to 10 minutes. The workshop summary. So through this workshop, as you have heard, the team here, working with their colleagues on the floor, have developed a standardized assessment, nursing assessment for all Allen Blair Cancer patients, Allen Blair Cancer Agency patients. They've introduced the distress screening tool to be used as part of that assessment for every patient, every time. They have ensured that the Regina Capel physicians have access to the Allen Blair EMR, as well as PACS, which they didn't have before, and lab results. They've developed an urgency scale for the Regina Capel palliative care referral form and streamlined the referral process. And they have made information on how patients can manage their pain and symptoms more readily available to patients and to nurses in the Allen Blair Cancer Center. So this was a huge piece of work, and we have many, many people to thank, as you can see by that list. But we do want to give a really big shout out to Susan Basilewski, Kevin Lacey, Kevin Garrett, and Bev Cobell, who on Tuesday afternoon were asked, do you think that we can give those physicians access to our EMR? And by Thursday afternoon, that EMR was being used in the pain and symptom management clinic. So it's fabulous. I also want to thank this team of folks right here, Julie and the rest of the RPIW team, for their commitment, their passion, their hard work. And there were some times when things did get kind of rocky, and their touchstone always was the patient. We're doing the right thing for the patient. So they certainly live the values that we would like to see all of these institutions live. So huge thank you to this team, and of course to Steve Mahalik, who is the best JBA consultant that we got going in Saskatchewan. Woohoo! So thank you to everybody.